Okay, so my patient was admitted with a right femoral fracture. They were getting out the bathtub and the right lower extremity gave out. They fell back into the bathtub. Luckily, there was no change in level of consciousness, so they did not black out or anything like that. Pain throbs at rest, and then it's exacerbated with movement. So my patient chronic problem list is benign neuroplasm colon, chronic kidney disease stage 3, GERD, hyperlipidemia, osteoporosis, renal failure slash insufficiency, synovial cyst, UTI, bursitis of the hip, depression, hematuria, hypertension, pre-diabetic, serum PSH level abnormal, and then TMJ disorder. So it'd be really important to watch their surgical wound and make sure that it's healing properly, because they are pre-diabetic. That could cause some delay with healing. So looking at their physical assessment, their vitals, their heart rate was 93, respirations were 18, O2 was 94, blood pressure was 133/70 on their right arm laying supine, 36.5 degrees Celsius for temperature. Pain, they literally just got up to use the bathroom. That hurt a bunch for them. So after that, that's when I asked the pain. They gave me a 9 out of 10 scale in the lower right leg. They described like in like the groin area, not lower right leg, upper right leg in that femoral area, but like in the groin, so like right in the middle of the leg. Heat and meds help, and then it feels like a sore, kind of like you just worked out, tender type of feeling. It's acute pain, and activity aggravates it, and then meds help. So upon another physical assessment, they were ANO times 3. They were able to move all extremities, 5 out of 5 strength. They were 80 Morse Fall scale. Glasgow Coma scale was 15. Lung sounds were clear bilaterally. 2+ pedal or radial pulse. Heart rate regular and clear. Bowel sounds were present in all 4 quadrants. They were active, and skin was intact. Some of the complications that I want to be looking for is any signs of internal bleeding, so high respirations, even high temperature, inflammation, redness, decrease in blood pressure. Looking for any type of complications with that surgical wound, making sure that it's healing properly because of that they are pre-diabetic. They didn't have any lines or tubes. They did have a saline lock, which I was able to administer some meds in, which I was really excited about. And yes, so their CAM score was negative and Braden score was 20. So psychosocial assessment, I noticed that they were very sarcastic, really in a good mood most of the time. As one of the nursing diagnoses that I will get into, I did have risk for depression, so we'll get into that later. But I did notice they seemed pretty okay right now, and they had PRN medications for they had PRN medication for depression if it was needed. So going through the medications now. So first med is pantoprazole, 20 milligrams PO at 7 o'clock. It's a delayed release, so make sure you do not to crush. And it's supposed to be before breakfast. The purpose is for GERD. Class is a PPI. Side effects are headache, diarrhea, dizziness. As a nurse, I want to monitor for decrease, asking the patient to make sure that there's a decrease in acid reflux, any type of heartburn, decrease in heartburn, hiccups, anything like that. and then monitor for headache, diarrhea, and dizziness. The next med is amlodipine, 10 milligrams PO daily, given at 9 o'clock in the morning. Class is a dihydropyridine calcium channel blocker. It's used for hypertension for this patient, and then side effects are edema, headache, fatigue, and rash. So I want to monitor a decrease in blood pressure. I want to make sure I take the blood pressure and heart rate before giving this to make sure it's appropriate, and then so no less than 60, and then monitor for edema, headache, fatigue, and rash. Next is bupropion, 300 milligrams POER. Do not crush, so make sure not to crush because it's extended release. 9 a.m. is when it's supposed to be administered. The class is a unicyclic amino ketone antidepressant, and the purpose is for depression. Side effects are rash, nausea, and migraine. I want to monitor patients' depression, so ask maybe 0 out of 10, see how they're also how they're acting, how they're responding to me. And then I want to monitor for rash, nausea, and migraine. Docusate, Senna, 1 tab PO bid at 9. It's a laxative stool softener. Purpose is constipation. Side effects are cramping, esophageal impaction, and diarrhea. So I want to monitor for constipation, see last bowel movement, listen to bowel sounds. Side effects, I want to monitor for any cramping, esophageal impaction, and diarrhea. Next is enoxaparin, 40 milligrams sub-Q every 24 hours at 9. Class is an anticoagulant. Purpose is to decrease thrombocysis. Oh my gosh, I know how to say this word. Thrombosis. Knew I had it. Thrombosis. Want to decrease thrombosis. I'm sorry, Nancy. Side effects is bleeding, anemia, and diarrhea. So I want to monitor for any edema, a decrease in edema, because make sure it's actually decreasing blood clots. You want to monitor for bleeding, anemia, diarrhea, and want to teach the patient to be real careful, because if they injure themselves, they can bleed more. Next is hydrocodone, acetaminophen PRN for 1 out of 3 pain, out of 10 Q4 every 4 hours. Class is analgesic, antipyretic, opioid. Purposes for pain. Side effects are lightheadedness, hepatotoxicity, dizziness, sedation, nausea, and vomiting. So I want to monitor the pain. That's the pain level. Monitor for lightheadedness, hepatotoxicity, dizziness, sedation, and nausea and vomiting. Next is morphine, 2 milligrams IV push, Q2 every 2 hours, PRN for pain, 4 out of 6 to 10. Class is opioid. Purposes for pain. Side effects are the sedation, respiratory depression, constipation, hypotension. So I want to monitor as for their pain. Make sure the pain is decreasing after being administered. Want to monitor for sedation, respiratory depression, constipation, hypotension. Next is on ondansetron, 4 milligrams IV push injection, Q every 6 hours, PRN. This is a 5-HT3 receptor antagonist. Purpose for nausea and vomiting, headache. Side effects are headache, constipation, and diarrhea. So I want to monitor for a decrease in nausea and vomiting, and then watch for headache, constipation, and diarrhea in the patient. Okay, and so labs that were taken, white blood cell, the labs that are actually abnormal. So the white blood cell count was high at 10.8, hemoglobin was low at 10.9, hematocrit was lowish at 31.8, red blood cell was low at 3.5. And neutrophils were high at 7.6. So this kind of makes sense. The body's reacting to the surgery, so a little decrease in blood is not crazy. And then labs, white blood cells being higher because a new thing is put into the body, so it's going to react to that. Neutrophils are going to also increase. So those make sense. Yeah, so this was all expected. So other disciplines that were involved, so PT was involved with this patient. They came in and they came in actually while I was there, and they were about to get them up, and I realized, I said, wait a minute. I said, it's okay if we administer their pain meds first, because I knew last time we got up to the bathroom, it was very painful for them. So I said, is it okay if we administer this pain meds? You come back 30 minutes later. Would that be okay? And they were like, yeah, that's cool. And so it was really nice to be able to like advocate for my patient, because I'm just a student. So I just felt like that was the best thing to do. And after I told you, you said that was a good thing. So that was really nice. But yeah, so PT took them around the building and watched how they were moving, watched their gait and all that. They could also get OT to practice doing ADLs. They were doing pretty good getting up and stuff, but maybe they can just practice doing it easier. I'm not sure. I think that would be a accurate way, though. In my opinion, I think that would be okay to, because they were able to get up, but it took them a lot to be able to get off the toilet, do little things that part of the ADLs. Nutrition, that's a good consult for them, because they are pre-diabetic, so it's important that they eat right so they don't cross that diabetic line. So I agree with that. And then case management is also something that needs to be consulted, because they are supposed to be getting discharged soon, so they will need to be able to figure all that out. And I do believe they have all the support and help from all the disciplines that were needed. They had everything that they needed that I was able to see. I did only see PT and I believe case management come in, and the doctors. But nutrition is something that I think that needs, if they haven't came in yet, they need to come in. Okay, so for safety risk, so they are a safety risk. Braden was a 20, Morris fall score was an 80. So it's very important, and they are down for activity as up with 1. So it's very important that we have the bed alarms on to make sure they can get up accurately. We are using the gait belt to make sure that we aren't pulling on them. We're holding on to something that is stable and on them. Being sure to check that site for any skin breakdown. They are able to move on their own, so we wouldn't have to rotate or anything, but those would be important. Okay, so now to my nursing intervention. So I had to prioritize these. So the 3 that I have is risk for injury, acute pain, deficient knowledge, and depression. So I made 4. I would prioritize these with, I would put risk for injury. I'll put acute pain first, risk for injury second, deficient knowledge, and then depression, based on how I felt, how they needed, what they needed. So let's start with acute pain. So this is the one I had first. I had this one first because their acute pain is making them a risk for injury, because they're in so much pain when they get up. So this is caused by the recent surgery, so it's important to assess vitals and pain level, use heat as a supportive therapeutic measure along with meds, and then encourage the patient to deep breathe and relax. Make sure I teach them how to do that. And then the goal for this patient was the patient would report less than a 3 out of 10, and they actually did for me. Well, partially met. They reported a 3, so I still feel like I met the goal. My next one was risk for injury, and so this was due to the weakness and sore pain in the right leg. So it's important to put the bed alarms on, assist with ADLs, activities as needed, as well as with mobility, and then administer pain meds before excessive activity. And I was able to do that. And then the goal was free of falls, and I met that goal. They were free of falls. Next from mine was deficient knowledge. So I actually was able to see this. So info was kind of misled. So basically, they were told to put ice on their incision sites and on the pain areas to make it feel better. And they were telling me it's not really working and everything. And she told me, then they told me that the doctor, another nurse came in. They were like, well, you shouldn't be putting ice on. You should put some heat on it. And the heat actually helped. So that was something that they didn't know. And I had to I actually teach them a little bit. I told them that ice is more for the inflammation, so right after surgery, but you want to put heat on something that's hurting afterwards, after the inflammation's down, because the inflammation's not there anymore. And so the goal for them was the patient will correctly perform and explain the reason, correctly perform the action, so putting the heat on there and explain back to me that that's why we did it. So they were able to do that. Lastly is depression I had, and then the reason was it was comorbidity, and then they have so many comorbidities that I put that on there, and then they were already at the hospital and they had to get readmitted, so I wanted to put that's also why I had depression. And then administer ordered meds for depression, had the patient rate of 0 to 10, and then encourage non-therapeutic measures. And the patient reported 0 out of 10 before the end of the day, and I was able to meet that goal. So I did feel confident with my patient. I felt like, one, we was able to really talk, and I just felt really relaxed. Each week I feel more relaxed. Even when I get to do new skills, I still get nervous, as you know, but I'm trying to relax more, feel more confident. I learned as a nurse, I was able to watch Nancy put in the IV, and I watched her roll the arm different ways to make sure and hold the vein so it doesn't roll. And I just was able to watch her put it in. It was a hard vein to put in, so it was really interesting watching that. Okay, I believe that the patient is receiving adequate care. I believe that I do wish that they were told heat way sooner, but I still feel like the meds were being administered. They were getting help to the bathroom. So I agree. And I really enjoyed myself. Truly, I really liked my patient, and I'm just excited for the rest of clinicals. Thanks.